Hi friends, welcome to the channel. It's a routine case planned for Phaco. It's a grade 2 nuclear cataract with a posterior subcapsular component. First, we do the fornix wash after putting the betadine 5%. It's a very important step, and if you use 5% betadine just before surgery and the contact time is almost like 2 to 3 minutes, it is equivalent to using the antibiotic drops 1 or 2 days before the surgery. So even if we are planning the surgery on the same day, we always use betadine 5% in each and every case with a contact time of 2 to 3 minutes at least. I generally advise my staff to put betadine only in the shifting area only. So they put a drop of Paracane and then put betadine 5%. So by the time patient comes to the OR, they have a contact time of almost more than 5 minutes. And again, when we take the patient on the table, we wash again the fornix and all with the BSS. Before that, we put the 5% betadine. It also helps in washing out any debris or dust if they are in the eye. Now back to the case. We are doing rhexis. Our aim is to have a rhexis of at least 5 mm. The rhexis is completed. A 5 mm rhexis is sufficient in most of the cases. Only in polar cataracts you can have a smaller rhexis, 4 mm, so that you can put the lens in the sulcus easily in the case of PC rent. Otherwise, in hard cataract, you should plan more than 5.5 mm for better manipulation of the nucleus during phaco and avoiding any stress on the zonules. But in general, 4.5 mm to 5 mm rhexis is sufficient doing the hydro, dissection and delineation. Multi-quadrant I do. Nucleus seems to be free. You have just seen the golden ring also. That shows the hydrodelineation was good. In between, you should decompress the nucleus to avoid any creation of the pressure behind the nucleus. Just cutting few lashes which were coming near the side port. Now, as we have planned, direct chop in this case, we will enter into the eye in Phaco 2 mode. I used a chopper from the side port. From the main port, as I enter into the eye, first we will remove the epinucleus and some cortex to reveal the endonucleus. As you can see the parameters. Now it's time for direct chop, burying the tip of the phaco probe in the center and with the help of the chopper, bringing it from outside in and separating apart. The patient head was tilted away from me a little bit, so it was creating some problem. Again tried for the complete chop but was not able to do so. The posterior capsular cataract sheet was thick, so trying to get multiple pieces. In these cases where you have a thick posterior sheet, either you should opt for a stop and chop, or you can try the flower petal pattern where you will multiple breaks and can lift the central posterior subcapsular sheet after making the multiple pieces. Here we were able to emulsify one of the nuclear piece. Once you create a space in the bag, it's easy to proceed further. As I am seeing, we are doing the vertical chop. separating the nuclear piece and bringing it towards the center. The emulsification of the nucleus should always be done in the center. That is the safest space. You are away from the posterior capsule and away from the corneal endothelium also. I am not able to catch the piece as it is attached to the bigger piece. Somehow I felt that the chamber needs to be refilled with the visco. In surgery, whenever you feel that you need to supplement the chamber with visco, you should always come out and supplement to have a clear cornea next day. You should never hesitate or delay that thing, because it prevents a lot of complications like corneal endothelial damage and posterior capsular rent. So these small steps makes the surgery easy further. Again, going with Phaco 2 inside the eye, and will emulsify and aspirate the remaining part of the nucleus. As you can see, my tip is buried and doing the vertical chop coming from equator towards the center. It's a kind of horizontal chop. Here you can see the thick sheet of posterior subcapsular cataract which was holding all the pieces together. Now we are emulsifying this. It also seems to be the last piece. Here you have to be slow and steady. It should not chatter a lot. If you apply the Phaco energy slowly, it will go well. Now we'll shift to Phaco 3. You can see the parameters. It's an epinucleus removal phase. The epinucleus is aspirated. Now it's time to do the cortical wash, doing the visco injection, HPMC 2%. Going inside with my coaxial. It's a bent coaxial. Personally, I am very comfortable with coaxial. You can use bimanual. Here the vacuum is almost 400. As you can see, we are pulling towards the center and then aspirating. If there any polish is needed or some cortical fibers are attached to the posterior capsule, I shift to IA2 where the vacuum is hardly 200. Now it's time to put the lens. Here one important thing comes is, whenever you are loading a lens which is not preloaded, always try to load it under the microscope. This is the one of the most important step. I have seen a lot of surgeons getting the lens loaded by their assistant without any microscopic view, and out of 100 cases sometimes the lens haptic gets stuck. I always load the lens under the microscope. Always check the cartridge. Then after putting the cartridge into the injector, I push and check that the movement is smooth, because the whole surgery we are doing to put the lens, and if there is a problem in putting the lens or loading the lens into the cartridge, if the haptic is stuck into the cartridge somewhere, so the surgery time will increase, complications will increase. You can have a broken haptic, or you can have a sudden push of the lens inside the eye. So it's better, if you have time, always load the lens yourself. As we are trying to push the lens inside the eye, the incision doesn't seems to be good, so I am enlarging little bit. As these are Indian lenses, the cartridge size is not very much fixed, can have variations. It was a 2.8 mm incision. Slight increase in the incision should be done. You should not try to push hard, because it can cause DM detachment, iris prolapse, iris pigment dispersion. I apply counterforce through the side port by using my dialer. Now the lens is pushed inside. One haptic went into the bag, pushing the other haptic inside the bag. Now it's time to do the visco wash. The vacuum at 400, the help of the coaxial, we are doing visco wash. Should give time for the visco wash. Visco should be washed properly from the anterior chamber, and also, if possible, you should go behind the lens. That is my favorite step. As you can see, just lifting the edge of the lens, going behind the lens and doing the irrigation aspiration behind the lens. The vacuum should not be very high, it should be about 200, that is sufficient. As you can see, as I remove the coaxial, there is prolapse of the iris. The reason can be the section length is not sufficient, or it can be a floppy iris. You can push back just by taping off the iris, and as you form the chamber, because of the chamber formation, iris get reposited automatically. If it doesn't, then you can use pilocarpine. Feel free to comment. Thank you.